You know, you rarely think about your body's major highway, the aorta, having a secret back door into your digestive system.
Mm.
But imagine if it did, and if that unexpected connection turned into a life-threatening emergency if ignored. That's the stark reality we're diving into today.
Oh,
Aortoenteric fistulas.
precisely. Yeah, we're going to unpack what happens when the aorta, the body's largest artery, develops this abnormal communication with the GI tract.
Mm.
And what's really key, I think, is understanding the two main types. It depends on the aorta's history.
Okay, so let's get this straight. There's primary aortoenteric fistula, or AEF. That's when this connection just happens, kind of out of the blue, with the aorta in its original state.
That's right.
And then there's secondary AEF, which implies something else was going on beforehand,
Yeah.
like surgery.
Exactly. A secondary AEF is amplification that pops up after a surgical procedure on the aorta itself. Could be a repair for an aneurysm, maybe a blockage, some other vascular issue. It's unfortunately the body creating a new problem from a previous solution.
Wow. It's almost hard to believe this was something doctors knew about centuries ago. I was reading Sir Astley Cooper. He described primary AEFs way back in 1829.
Yeah, that's right.
Especially with aortic aneurysms. And then the first successful repairs of the secondary kind started, mid-20th century?
Brock in 53, Heber, Mackenzie later in the 50s.
It's incredible how far medicine's come, yet this is still a huge challenge for surgeons.
It absolutely is. Despite all the progress, both primary and secondary AEFs remain incredibly difficult to diagnose and to treat. Tragically, without intervention, they're almost always fatal.
Wow.
And even with the best surgery, the risks, the complications, they're significant.
So for someone listening, maybe they haven't encountered this before. It might sound incredibly rare, almost unheard of. Why should this be on our radar?
That's a really important question because while, the overall occurrence might be uncommon, understanding AEF is critical, especially if you or someone you know has a history of aortic problems.
Or aortic surgery.
Exactly. Or surgery. The real hurdle here is often the diagnosis. Because it is rare, it's not always the first thing that jumps to a clinician's mind. That's why you hear this phrase a lot in medicine. Maintain a high index of suspicion.
Right.
Basically, be aware this is a possibility, especially when patients show up with certain telltale signs.
Right, so the mission for this deep dive is to really dissect these AEFs. We're going to explore the causes, the clues that help doctors spot them, and the different strategies for treatment, all based on some detailed medical textbook chapters we've got here.
Precisely. So let's start with primary AEF. While it's quite rare overall, maybe 0.04% to 0.07% in autopsy studies.
Tiny numbers.
Right. But the picture changes quite a bit when you focus on people with abdominal aortic aneurysms, or AAAs. In that group, the incidence jumps. It's somewhere between, say, 0.7% and 2.4%. And what's really striking is that in most primary AEF cases, something like 83%, an aneurysm is involved.
So besides aneurysms, what else can cause a primary AEF?
Yeah.
Sounds like there might be other culprits.
You're right. While an expanding aneurysm pressing on the gut is the most common cause, other things can contribute. Foreign bodies, maybe something swallowed.
Really?
Yeah. Tumors near the aorta and GI tract, radiation therapy to that area, certain infections. Historically, things like TB, syphilis.
Right.
More recently, bacteria like Klebsiella, Salmonella are implicated. And interestingly, even some GI diseases like peptic ulcers or gallstones that erode through the bowel wall can, in rare cases, lead to a primary AEF.
That's quite a range. Are there any characteristics that make certain people more likely to develop one? Demographics.
The data points to a few things. The average aortic diameter in these cases is around 6.2 centimeters.
Okay, pretty enlarged.
Yeah, gives you a sense of the aneurysm size often involved. Average patient age is about 64. And there's a notable gender thing. Males are affected about 3 times as often as females.
And where in the digestive system do these connections usually form? I remember reading one spot is particularly vulnerable.
Yes. The third and fourth parts of the duodenum, that's the first bit of the small intestine, right after the stomach. That's the most common site, maybe 54% of primary cases.
Why there?
Well, the main theory involves the ligament of Treitz. It basically anchors this part of the duodenum, makes it somewhat fixed, so it's more susceptible to that constant pulsing pressure from the aorta nearby. But it's not the only place. AEFs also happen in the esophagus, that's about 28%. Other parts of the small and large bowel, maybe 15%. Even the stomach, though that's rare, maybe 2%.
So how does this connection actually form? Is it just the mechanical pressure wearing things down?
Well, The exact mechanisms aren't fully pinned down, but the main ideas involve a mix of factors. Mechanical stress, definitely, infection can play a role, inflammation in the tissues.
Yeah.
But in most primary AEF cases, it really seems like the mechanical aspect, that relentless rhythmic pressure from an expanding aorta pushing on the GI tract wall, that's the primary driver.
Like water wearing away rock.
Sort of, yeah. This constant pressure can compress the bowel, cut off its blood supply ischemia, which weakens the wall over time, eventually letting it erode, and pop, you get the fistula.
Okay, that gives us a good picture of primary AEF. Now let's shift to secondary AEF.
Yeah.
I mentioned this is actually seen more often.
That's right. It's more common. And the key difference, as we said, is that history of prior aortic surgery.
Right.
Secondary AEF can happen after open surgical repair or even after the less invasive endovascular repair, EVAR. The reported incidence after open abdominal aortic graft reconstruction is somewhere between 0.36% and 1.6%.
And there's a delay, you said?
Yeah, what's interesting is the time lag. The average time between the initial surgery and symptoms showing up is usually around 2 to 6 years, so it's typically not an immediate thing.
Okay, so it develops sometime after the surgery, and it involves this connection between the GI tract and the repaired aorta, which usually has some kind of artificial graft material, right?
Exactly. We often think of synthetic grafts, Decrin, PTFE. But secondary AEFs have also happened with aortic homografts from human donors and allografts from the same species. And just like primary AEF, the distal duodenum and proximal jejunum are common spots.
But it could be anywhere along the graft.
Pretty much, yeah. Depends on where the graft was placed in the first place.
I remember reading secondary AEFs are sometimes classified based on where the connection is relative to the graft itself.
Yes, that's a useful distinction. We talk about a graft-enteric fistula versus a graft-enteric erosion.
Okay, what's the difference?
A graft-enteric fistula is a direct communication. Bloodstream inside the graft connects right to the inside of the GI tract, often right at the suture line where the graft was sewn on.
So big bleed potential.
Exactly. Often leads to very sudden dramatic hemorrhage. Then there's graft-enteric erosion. That's a communication between the GI tract and the graft material itself, but maybe not right at the suture line. It could be through the fabric interstices. These might initially present more with signs of infection because bacteria from the gut can kind of slowly seep through the graft material.
Yeah, that makes sense. So for secondary AEF, what factors might put someone at higher risk after their initial aortic surgery?
Several things, both patient-related and surgical. A history of multiple vascular procedures already, any problems with wound healing after the first surgery, presence of infection at the site, if the original operation was an emergency, and any technical issues, maybe errors during the initial graft placement, are all considered risk factors.
And the underlying processes leading to secondary AEF similar to primary or different things at play?
There's some overlap, but infection really takes center stage in secondary AEF.
More so than mechanical pressure.
Often, yes. While mechanical factors like the graft rubbing the bowel and technical errors can contribute, infection and the inflammation it causes seem to be major drivers. Studies show these infections are often polymicrobial, multiple types of bacteria. And interestingly, yeast, especially Candida, is found pretty frequently too, in both open and endovascular repairs. This infection leads to inflammation, weakens the suture line, can cause pseudoaneurysms.
False aneurysms.
Right, and eventually erosion into the nearby bowel. There's also some thought that certain bacterial characteristics, like enzymes that break down tissue, might play a role, but that needs more research.
You mentioned technical errors during the first surgery. What kind of things?
Could be unintentionally introducing bacteria to the graft during implantation, or directly injuring the duodenum, maybe with a sharp instrument, or heat from cautery.
Ouch.
Or even just excessive pulling or retraction of the bowel, or letting it get too dry during the operation.
So prevention during that first surgery is key.
Absolutely. And techniques have improved, better patient prep, appropriate antibiotics. Surgeons also take steps during surgery, using warm, moist sponges to protect the bowel, packing it carefully, sometimes using isolation bags. Even the surgical approach, like retroperitoneal, might reduce adhesions. And importantly, placing tissue between the graft and the bowel, closing the original aneurysm sac over the graft using an omental flap.
That's the fatty tissue.
Yeah, from the abdomen. Or even using bovine pericardium, creating a protective barrier.
Sounds like a lot goes into trying to prevent this down the road. Now, let's talk about a more recent development.
Yeah.
AEFs after endovascular repair, EVAR. Seems like we're hearing more about this.
Absolutely. We are seeing more reports of AEF after both EVAR for the abdominal aorta and TBAR for the thoracic aorta. The proposed mechanisms here have some different angles.
Like what?
Persistent endoleak is one. That's where blood keeps flowing into the aneurysm sac around the graft.
Okay.
Makes the sac grow, potentially erode into the bowel. Multiple attempts to coil off an endoleak might also contribute. Direct erosion of the stent graft itself through the aortic wall. Endotension, and even infection present when the endograft was placed.
I remember reading about a study, Fisto, that looked into this. What did they find?
Yeah, Mephisto was a big international study, over 3,900 EVAR patients. They found AEF developed in 22 of them. But the incidence was way higher, 3.9%, when EVAR was done to treat a pseudoaneurysm that formed after a previous open repair.
Compared to a standard aneurysm.
Right, compared to 0.46% for a standard atherosclerotic aneurysm. They also found strong links between using EVAR for these anastomotic pseudoaneurysms and also doing EVAR urgently or emergently and developing AEF later.
Interesting. Did the type of graft matter?
No, they didn't find any correlation with the specific brand or type of endograft. The higher risk with pseudoaneurysm suggests maybe a low-grade infection or even a very early subtle AEF was already there sometimes. And in urgent or emergency cases, maybe hematoma pressing on things or just more inflammation contributes.
That's really insightful. So it's not just the device, but the context what's being treated, the urgency. What about those endoleaks and graft defects themselves after EVAR?
Yeah, a significant chunk of AEFs after EVAR, maybe 37% in one review, were linked to either an endoleak causing sac expansion or just sac expansion even without a clear endoleak. And when they looked at the devices that had to be removed, about 30% had some kind of structural defect, like a fracture in the stent framework, fabric erosion, significant kinking.
So getting the initial EVR technically right is probably crucial for prevention.
Very likely, yes. It really highlights the importance of that initial technical success.
Okay, so we've seen all these ways AEFs can develop. How do patients actually present? What are the signs, the symptoms that might make a doctor suspect this?
For primary AEF, there's that classic triad from Sir Astley Cooper: GI bleeding, abdominal pain, and a pulsatile mass you can feel.
Right. Okay.
But while that's classic, it's important to note it only happens together in a small percentage, maybe 11%.
Only 11%. Okay.
Individually, the most common symptom is GI bleeding. That occurs in anywhere from, say, 64% to 94% of patients.
So bleeding's the big one.
Often, yes. Abdominal pain is also frequent, maybe 32% to 48%. Feeling a pulsatile mass is less common, maybe 17% to 25%. Other things reported include back pain, fever, signs of sepsis.
And blood tests.
Not always clear-cut. Maybe 2/3 have low hemoglobin, showing blood loss. About a quarter might have a high white blood cell count, suggesting infection.
What about secondary AEF presentation? Similar symptoms?
Bleeding is definitely major there, too, around 73% in one review. But sepsis seems even more prominent, maybe 41% of cases.
Wow.
Other things can include abdominal or back pain, maybe 22%. Blood clot in the graft limb, thrombosis, that's about 14%. A fistula or opening in the groin, 11%. Peripheral abscess, 8%. Femoral pseudoaneurysm, 5%. Even peritonitis, 5%.
You mentioned a herald bleed earlier. That sounds like a really critical warning sign. Can you elaborate?
Yes, the herald bleed. It's classic, very important. Can happen in both primary and secondary AEF. It's basically a small, often temporary episode of GI bleeding.
Why temporary?
It happens because of a brief vasospasm, the blood vessels clamping down, and a clot forming that temporarily seals the fistula.
Okay.
The danger is this minor bleed often comes before a major life-threatening hemorrhage, sometimes just hours before, but it could be weeks or even months.
It's a crucial warning.
Absolutely. Even if the bleeding stops on its own, it's a huge red flag that something serious is wrong and needs immediate investigation.
It really drives home that high index of suspicion you mentioned.
Right.
Because if doctors miss that herald bleed or don't consider NCF, the consequences are dire.
Exactly. Because AEF is relatively rare, diagnosis is often delayed. And that delay means treatment gets pushed back, worsening outcomes significantly. Any patient with a history of AAA or an aortic graft who presents with unexplained anemia, GI bleed, or sepsis symptoms, AEF needs to be high on the differential diagnosis list early on.
So when a doctor suspects AEF, what's next? How do they confirm it?
The first step in diagnosis really hinges on how stable the patient is. If someone's having massive GI bleeding and has that history of aneurysm or surgery, the diagnosis often happens right there on the operating table during an emergency exploratory laparotomy.
Got it. Straight to surgery.
Right. But if the patient is hemodynamically stable, vital signs, Okay, there are three main tools: CT scan with IV contrast, EGD, that's an upper endoscopy, and angiography.
There used to be some debate about the order, right? EGD first.
Yeah, older guidelines might have suggested EGD first, then CT, then maybe angiography, but the thinking has shifted. Now, CT with IV contrast is generally the preferred initial test in stable patients.
Why the shift to CT?
Mainly because it's non-invasive, usually readily available, and crucially, it doesn't carry the risk of dislodging a clot that might be temporarily sealing the fistula. That's a potential worry with endoscopy.
Makes sense. What does a CT show that points towards AEF?
Several things can be red flags on CT. Blurring or loss of the normal fat plane around the aorta, fluid and soft tissue thickening around a graft. Ectopic gas air where it shouldn't be, like in the aneurysm sac, especially if it's more than 3 months post-op.
Okay.
Tethering or pulling of thickened bowel loops towards the graft, and rarely you might actually see contrast leaking from the aorta into the bowel.
Wow.
CT actually has the highest detection rate, around 61%, and it gives good info about other vessels too, which helps plan surgery. Oh, and one important point. Oral contrast is usually avoided if you suspect AEF.
Why is that?
It can sometimes obscure the view, especially of an endovascular repair.
Okay. What about EGD? You said its detection rate for AEF itself is lower. What's its role then?
Endoscopy, EGD, is still crucial for anyone presenting with upper GI bleeding. While it might only directly spot the AEF in maybe 25% of cases,
Right.
its main job here is to rule out other, more common causes of bleeding, like ulcers, varices.
Got it. Exclude other things first.
Exactly. To give EGD the best chance of maybe seeing an AEF, the endoscopist really needs to carefully check the third and fourth parts of the duodenum. Sometimes requires special scopes, pediatrics, side viewing, double balloon endoscopy.
So a thorough look is needed.
Yes, and a skilled endoscopist with a high suspicion might see exposed graft, an ulcer with a clot, maybe feel an extrinsic pulsation. But again, primary role is exclusion. And it's generally only for stable patients, sometimes done in the OR, ready for immediate surgery if needed.
And angiography. Sounds like its diagnostic role is also limited.
That's right. Angiography's detection rate for AEF is around 26%. It's not great for diagnosis itself, but it is useful for mapping out the arteries before surgery.
Okay.
And it might show indirect signs of a secondary AEF, like a pseudoaneurysm at the anastomosis, graft kinking, maybe deteriorating graft material. But often in stable patients, the fistula is clotted off, so you don't see the direct connection on angio.
But it can still be used therapeutically.
Yes, as an adjunct. You can use it to place an occlusion balloon proximally, above the fistula, before starting open surgery. Helps control bleeding.
Are there any other diagnostic tests used sometimes?
Yeah, others have been used, but they're generally less accurate or take longer. Tagged white blood cell scans, nuclear scans. MRMR can be helpful for graft infection and AEF, but often tough in critically ill patients. Ultrasound contrast GI studies generally avoided.
Okay.
There's also a rare type, aortoappendiceal fistula aorta to appendix. Patients might have bright red rectal bleeding, might need colonoscopy, tagged red cell scans.
Wow.
And very rarely, plain x-rays might show weird skeletal signs of systemic infection, like hypertrophic osteoarthropathy or multifocal osteomyelitis linked back to an AEF.
It really highlights how tricky diagnosis can be, different presentations, limitations of tests. So once AEF is diagnosed or strongly suspected, what are the treatment options?
Okay, the first, most crucial point. Trying to manage AEF without surgery, that's invariably fatal.
Right. Surgery is the only option.
Surgery is the only option offering any chance of survival. The approach depends on whether the patient's actively bleeding, if it's primary or secondary, signs of sepsis, extent of underlying aortic disease.
So urgency dictates the first steps. What about a patient who is actively hemorrhaging or septic?
Yeah, in those urgent cases, the immediate goals are stop the bleed, fight the infection. Fast. That means good IV access, central lines usually. Massive transfusion protocol activated.
Oh.
Broad-spectrum antibiotics and antifungals started right away. Anesthesia needs to be ready for massive transfusion in patients who often have other major health issues, heart failure, lung disease.
Complicated.
Very. And keeping the patient warm is critical. Hypothermia worsens bleeding problems.
And the surgical approach itself? Open. Endovascular.
Initial approach might be open midline incision, Or in specialized centers, maybe initial endovascular control inflating balloons inside the aorta.
If the surgeon's experience.
Right. And maybe a brachial access if the groins are badly scarred. You need proximal control above the fistula. Infrarenal, or often supraceliac, is preferred in open surgery. And distal control below the fistula, clamping iliacs or using balloons.
Then separate the fistula.
Carefully, yes. Sharp dissection. Then deal with the graft if it's secondary AEF, removing it. Endografts can be tricky with their fixation elements. Often need to gently move them proximally to release. Distal limbs are usually easier.
And after the graft's out.
Depends on infection signs. If no obvious local infection, maybe an in situ repair, new graft in the same spot, prosthetic, cadaveric, vein. If there is significant infection, then oversew the aortic stump, cover it with omentum.
Right, that fatty tissue again.
Yeah. Then thorough debridement of infected tissue drains, and usually an extra anatomic bypass rerouting blood flow elsewhere away from the infection.
Wow. And managing the hole in the bowel itself sounds just as critical.
Absolutely critical. How the bowel defect is repaired is a major factor in success. GI complications post-op significantly increase mortality.
So how is it repaired?
Once the aorta is controlled, you carefully dissect the bowel off the aneurysm or graft. Sometimes leave a bit of graft on the bowel wall to minimize contamination, or do a temporary repair initially.
Okay.
Reviews show, for aortoduodenal fistulas especially, more complex repairs like resection or diversion have lower recurrence rates than just sewing the hole shut.
Right.
And interestingly, putting omentum or other healthy tissue between the repaired bowel and the artery lowers mortality, regardless of how the bowel was closed.
So that interposition is key.
Seems very beneficial. More recent studies really emphasize aggressive debridement of damaged bowel, then a careful, tension-free anastomosis, sewing healthy edges together with good blood supply. Often means resection, not just patching, and being quick to reoperate if there's any concern about mesenteric ischemia.
Reduce blood flow to the gut.
Exactly. While we see these trends, there's still a lack of direct studies comparing simple repair versus resections specifically for AEF.
What about stable patients? Maybe after a Harrow bleed stopped. Does that change the surgical plan?
Yes, if the patient's stable, not actively bleeding, there's more time for detailed evaluation and planning. You can sometimes even reverse the order of surgery.
How so?
Do the extra anatomic bypass first.
Before dealing with the infected aorta.
Right. There were concerns about seeding the new graft, but that hasn't really panned out if done carefully with antibiotics. Doing the bypass first is good if there's no infection, but the old graft still works, or if you expect a long clamp time during the main surgery.
Why?
It ensures continuous blood flow to the legs and pelvis throughout the whole process. Reduces ischemia risk.
Makes sense. Any other pre-op steps for stable patients?
Often, yes. Cystoscopy, looking in the bladder and placing ureteral stents before the main abdominal surgery, helps surgeons identify and protect the ureters during dissection in potentially inflamed, scarred areas.
Okay, let's get into specifics. Primary AEF versus secondary. Are the surgical strategies different?
For primary AEF, management depends on infection evidence at surgery, mild contamination, often in situ replacement of the aorta, plus debridement and long-term antibiotic antifungals.
And if it's really dirty? Gross contamination, sepsis.
Then usually a bigger operation. Aneurysm resection, omentoplasty, retroperitoneal debridement, and extra anatomic bypass. But that carries higher mortality and limb loss, so it's reserved for really bad contamination.
Okay.
Remember, most primary AEFs are duodenal proximal small bowel, tends to be less contaminated than the colon. But all primary AEF patients need post-op antibiotics and antifungals. Broad spectrum first, then tailored to cultures. Maybe a week if culture's negative, 4-6 weeks if positive.
Got it. Now for secondary AEF, what's the menu of surgical options?
Quite varied. You've got graft excision alone, just take it out. In situ replacement, new graft in the same spot. Graft excision and reconstruction with the patient's own vein, that's the NAIS procedure. Extra anatomic revascularization plus graft excision. And endovascular repair, usually needing lifelong antibiotics.
When would a surgeon just remove the graft and not replace it immediately?
Feasible sometimes, mainly if the original graft was for occlusive disease or if it's already clotted off completely.
And the patient has collateral circulation.
Exactly. If they've developed enough alternative blood flow, assessed pre-op with imaging. Maybe do an endarterectomy and patch if the original graft was end to side. But generally not done if the graft is patent, was for an aneurysm, or if the patient has foot pulses, high risk of limb ischemia then. It's a balance, recurrence risk versus ischemia risk.
Okay. Extra anatomic bypass Sounds complex. When is that the go-to?
It was a mainstay before in situ gained favor. Still valuable, especially with gross contamination or for stage repairs. Often uses externally supported PTFE grafts.
How's it done?
Either after the main abdominal part with fresh sterile gear, or sometimes before in stable patients, as we discussed, to maintain leg perfusion.
Right.
Common type is axillobifemoral armpit to both groins. If femorals are involved, maybe axillo-unifemoral or popliteal grafts tunneled laterally. Left side tunneling can be tricky after some retroperitoneal approaches. Sometimes use composite grafts, synthetic in clean areas, autogenous like vein, down to contaminated femorals. Soft tissue coverage in the groin is key, muscle flaps, and antibiotics, of course. Risk of bypass graft infection is still there, maybe 15–25%.
What are the long-term outcomes like?
Can be mixed. Poor long-term patency sometimes, higher amputation rates, reinfection mortality can be high, 18–43%, though lower if staged. And aortic stump rupture is a major risk, up to a third within 3 months. Patency at 5 years, maybe 64–80%.
So in situ replacement sounds potentially better long-term.
It's gained popularity for that reason, using cryopreserved allografts, antibiotic-soaked synthetic grafts, or silver-coated doctrine.
How does it compare to X-ray anatomics?
Limited direct comparative data, but some studies suggest maybe no superiority of either approach overall. A meta-analysis did show lower operative mortality for rifampin-bonded grafts versus extra-anatomic for graft infection. Potential benefits of in situ? Maybe better long-term patency, lower stump blowout risk, less risk of clots going to kidney arteries, keeps colon pelvic blood supply intact. Reinfection rate with cryopreserved allografts reported around 14% in some series.
And the neonatal Toilac system procedure, NAS, using the patient's own vein. What's the thinking there?
NAS uses the femoropopliteal vein from the leg to build a new aortoenteric system entirely from the patient's own tissue.
Main advantage.
Infection resistance. It's autogenous tissue. Also avoids aortic stump issues. Might be more cost-effective than cadaver-treated grafts. Usually no need for lifelong anticoagulation.
Down the size.
Long vein harvest time. Can't really stage the procedure. Risk of venous insufficiency, swelling, pain in the donor leg. Rarely compartment syndrome. Outcomes in the big series have varied, so we need more comparative trials, specifically in AEF repair, not just general graft infection.
Okay, lastly, endovascular repair for AEF. Given the risks of open surgery in sick patients, it must seem tempting.
It definitely looks appealing initially. Less invasive, quick hemorrhage control, less physiological stress maybe. High morbidity mortality with open AEF surgery makes it seem attractive.
So people are using it.
There's been an increasing number of case reports using EVAR for AEF over the last decade or so. But it violates fundamental surgical principles.
How so?
You're not repairing the fistula directly. You're not removing infected tissue. You're leaving the infected aorta or original graft in place.
Not ideal long-term.
Exactly. A 2009 systematic review found successful EVAR replacement, but very high complication rates, 44% persistent recurrent infection or bleeding. Mortality was 29%, mostly sepsis, at about 13 months follow-up. Pre-op infection and post-EVAR complications were bad signs. Conclusion then was, EVAR should probably be a temporary measure, a bridge to definitive open repair.
Any more recent data?
Yeah, a 2011 multi-center study directly compared EVAR to open repair for AEF. Found a short-term morbidity benefit for EVAR, but that advantage was lost by year 2. More bleeding, sepsis, and AEF recurrence in the EVAR group later on.
Oof.
And what's really concerning are recent reviews suggesting outcomes are almost uniformly fatal if AEF or infection recurs after an initial EVAR for AEF.
So definitely not a definitive cure.
Generally not. There's some interest in TEVAR for aortoesophageal fistula, mainly to control bleeding and reduce the very high open repair mortality there. A 2014 meta-analysis showed TEVAR alone didn't improve survival much, but a combined approach, maybe staged graft esophageal resection and using antibiotics for over 4 weeks, significantly decreased mortality.
So the bottom line on endo for AEF.
Current thinking. It's a valuable bridge to open repair after stabilizing the patient and controlling infection. Or maybe an option for patients with very limited life expectancy where palliative goals are key.
It sounds incredibly complex, a real surgical challenge with no easy answers. So what are the overall results, the conclusions from all this data?
For primary AEF, standard aortic reconstruction plus bowel repair works reasonably well in many cases. Operative mortality around 36% in one review. Survivors often do okay long-term. Similar results from places like the Netherlands.
Secondary AEF.
Untreated secondary AEF, as we said, leads to hemorrhage, sepsis, death. Operative mortality rates vary wildly, 13% to 86%, average maybe 30–40%, amputation rate around 10%. 3-year survival, maybe 50%.
Grim numbers.
It really underscores the massive physiological stress. And AEF treatment often has higher mortality, longer hospital stays, more transfusions than just treating aortic graft infection without a fistula.
So still lots of debate on the best approach.
Definitely ongoing controversies. Simple graft excision might work in very select cases, chronic occlusion. In situ repair, allograft, antibiotic silver grafts, and NEIs are used more now in chosen patients. Extra anatomic is still a safe alternative for gross contamination, especially if staged. And EVAR is temporary palliative.
What are the keys to success then?
Seems to boil down to timely intervention, appropriate patient selection for the right procedure, effective bowel repair, and good long-term follow-up. The textbook chapter even has a nice algorithm summarizing the steps based on stability assessment, support, imaging, then tailored surgery.
This has truly been a deep dive into a very complex, critical condition. To wrap things up, what are the absolute key takeaways our listeners should remember?
I'd say, first, know the difference between primary AEF, native aorta, and secondary post-surgery. Second, diagnosis is tough. High suspicion is crucial, especially with that history plus GI bleed. Third, the Herald bleed is a major warning sign, even if it stops. And finally, treatment is complex, surgical, with diverse options. No single best approach fits everyone.
And what's one intriguing detail about AEF that might leave our listeners thinking a bit further?
Perhaps the most thought-provoking thing is that ongoing debate and the lack of big, definitive studies comparing all these surgical treatments. It really highlights the complexity, the rarity, and how individualized managing this condition has to be.
It really makes you consider, doesn't it? How do these mechanical forces, like blood pressure, interact with infection, and then the patient's own health factors, to create such a rare but devastating problem? It's a fascinating and frankly scary interplay that doctors are constantly working to understand and treat better.